Good afternoon, everyone, and welcome to Dreamforce. We hope that your conference experience so far has been magnificent, and thank you for joining us here this afternoon. I have the distinct honor of introducing and welcoming to the stage one of the titans in leadership in the fight against HIV/AIDS. When our next speaker moved to Congress as a freshman in 1987, less than 4% of her colleagues were female. And despite strong guidance otherwise from her more senior members, she declared in her opening speech that she was there to represent San Francisco and she was there to fight AIDS. And fight AIDS she has in a way that no one could have ever possibly imagined. She was instrumental in the creation of the housing opportunities for people living with HIV/AIDS. She's expanded Medicaid. She increased funding for the Ryan White Care Act and was instrumental in creating the Minority AIDS Council. During her 4 years as Speaker of the House, she led the effort to remove the restriction on federal funding for needle exchange, and the federal government lifted the ban that prohibited HIV-positive people traveling to the United States. And most recently, she led the fight that ultimately delivered millions of affordable healthcare insurance under passage of the Affordable Care Act. Please join me in welcoming my speaker, our U.S. Democratic leader, Nancy Pelosi.
Thank you, James.
Thank you.
Thank you, James, for all that you do. Aren't we proud of the San Francisco AIDS Foundation and James's work? Thank you, James, very much for your very kind introduction, which I will accept on behalf of the people of San Francisco, because everything that was done there sprang from ideas and challenges that we faced here. And I'll be fairly immodest in accepting the credit, again, on behalf of the people of San Francisco. When I made that statement in my first speech on the floor, people came up to me afterward and said, "Why on earth would you ever talk about AIDS in your first speech on the floor of the House? Why did you say that you came here to fight HIV and AIDS?" I said it because that's why I came here, to fight HIV and AIDS. But just to show you the stigma, or worse, that was associated with it. That's almost 30 years ago, a long time ago. All of the good things that came after that, whether it was the Ryan White Care Act, sprang from San Francisco. Our community-based prevention, our community-based research, our community-based care. Dr. Volberding and so many others, Dr. Steve Morin, who was on my staff, but Dr. Volberding, what was advanced here became the model for the country. So I happily take credit for the fact that it passed, but it passed because it was excellent and it came from the people of San Francisco. When we talk about housing opportunities with people with HIV/AIDS, it sprang from San Francisco, that people had special challenges. And if you're challenged with HIV and AIDS, you cannot be homeless. People said to me, well, people have cancer, people have this, people have that. We don't have special housing for them. I said, well, we have a model for it. In San Francisco, it became the law, but it sprang from the intellectual resources and the community involvement in San Francisco. The list goes on and on. I'll tell you this. If you had told me when I was standing on that floor in 1987, talking to my colleagues for the first time and mentioning HIV/AIDS, that almost 30 years later, we would still not have a cure, I would never have believed you. That we would still not have a vaccine. Now, we've made tremendous progress in improving the quality of life and having interventions that push off, until we find a cure. But this is a very resourceful virus. Just when you think you have it, it mutates. So we have to be entrepreneurial in our thinking, and that's why I'm so glad we're here with Dreamforce, because these are entrepreneurial thinkers, thinking in different ways about how to address a challenge of a virus that should have long ago been destroyed, but that's still there. So today is a very special day because of the focus on HIV/AIDS, the Global Fund, that Dr. Birx, I should say Ambassador Birx, Ambassador Gooseby, Ambassador Dybel, James. The panel you'll hear from are fabulously impressive intellects on this subject. Ambassador Gooseby and Ambassador Dybel treated people with HIV/AIDS. So not only have they served in a policy-making leadership role, but they have done the job person to person. And that's what San Francisco's model was all about. So we have, we want, today's theme is to help end AIDS for good. That means forever. We've always talked about one day, some years from now, kids will go to a museum and they'll say, what's that? What's AIDS? And we'll say, it was a terrible thing, a terrible intervention into the life of our community. But we're not there anywhere near that yet. But we are there in prolonging life, improving the quality of life. For years, I had people coming to my office where we were trying to get cures from, shall we say, other countries, one way or another. Then a few years later, these people who were on the verge of leaving us, they were coming to our office to help make out wills, were coming in looking for jobs. And then later, getting married. I'll just say this, I do think the mobilization against AIDS, and in San Francisco, we knew that if we were going to be successful in mobilization against AIDS, it had to be global. It couldn't be parochial. We treat people individually and community-wide, but we had to have a global approach. And so we would have parades going back over 25 years, candlelight processions, all the rest of that, but the international mobilization against HIV/AIDS, and that's what we'll be a good deal of what we'll be focusing on today. But it is, again, a public health issue. And we have to take public health issues, whether they're HIV/AIDS, Zika, opioids, you name it, we have to take it to a place where when the challenge is anticipated, that we're ready. If it surprises us, that we are funded without any question. And so it's about resources, financial, intellectual, compassion-wise, respectful, and the rest. But again, it's been here too long. So when we say we're going to help to end AIDS for good, that's forever, for good, forever, but also for the good of the people infected, the people we want to protect from being infected, the communities that suffer from it, and the whole economies of country that could be devastated by it. Mark Benioff has been just remarkable in embracing this as a challenge and as a goal to be achieved. Bono, I don't think anybody's done more than Bono. So the combination of those two is something so magical that I'm sure that what is happening here today will make a tremendous difference. Yeah, you and I are very eager to hear from our experts on the subject, so I'm going to yield to them with the greatest respect and admiration and gratitude for all that they have done, and with appreciation for all of you to make this a priority to be here today. We will not rest. We will not rest until we end this scourge of HIV and AIDS. Thank you for your interest. Thank you.
Thank you.
Thank you, you need to take
Oh, yeah, sure. I'm not sure if you could hear us backstage, but I turned to our Secret Service person and said, I kind of have a professional crush on your boss. Hello, everyone. I'm James LaDuca, San Francisco AIDS Foundation. I'm going to start by telling a little bit of a personal story. A few years ago, I was confronted by an unexpected divorce from my partner of 7 years. The news knocked me to my knees. I spiraled into depression, which was accompanied by behavior that is often triggered when you hit one of life's rough patches. It's what HIV experts call a season of risk, and it can happen to any of us. Personally, I got through mine thanks to San Francisco's network of free services for sexual health, mental health, and substance health that were available to me on demand without shame or judgment. The question, am I worthy of love and belonging, is one of the most fundamental we confront in our work. It respects a universal human desire to be seen, to be valued, and to connect. This city's name is synonymous with a model of care designed to restore dignity and heal the wounds inflicted by homophobia and poverty and racism and violence. See, right here in San Francisco, for 30 years, we have known that people who are gay, people who are trans, people who engage in sex work, people who use drugs, people who are homeless, people who live with HIV, we are all first and foremost people, and we are all worthy of love and belonging. And while that's not unique to San Francisco, I can tell you it's not nearly common enough. And if that is not leadership and boldness, I don't know what is. And that's what we're here to talk about today. Leadership and boldness in the response to HIV/AIDS. And we have assembled a mind-blowing talent of panelists to speak to you about this. All of them have direct personal experience here in San Francisco and in different communities across the United States, but all of them are also global leaders. And they're here today to bring real-life examples from their work in what leadership and boldness means to them, to the fight against HIV, and most importantly, to ending the epidemic. So let's hear from them. It's my honor to bring them out to stage. First, Dr. Mark Dybel, Executive Director of the Global Fund to Fight AIDS, Tuberculosis, and Malaria. Next, we have Dr. Eric Goosby. He is the U.S. Special Envoy on Tuberculosis at UCSF. Next is Ambassador Deborah Birx. She is the U.S. Global Coordinator on HIV/AIDS. And last but not least, Mr. Ernest Hopkins, San Francisco AIDS Foundation's Director of Legislative Affairs. Please join me in welcoming them. Hi. Nice to see you. Good to see you. So let's get this started. I have a question that I'm going to ask everyone to respond to, because I think you all have a lot to offer in this area. HIV, arguably more so than any other disease, is tied to social and cultural issues, making prevention of HIV dependent on a range of factors that aren't really medical. Based on your experience, can you explain to our audience what makes HIV so difficult in this sense, and why boldness and leadership in the response needs to be more than just about medical intervention to change the course of the epidemic? And let's start with you, Mark.
First, thanks a lot, James, and thanks for sharing some of your story. And we should all begin by thanking Leader Pelosi and actually all of Congress and sequential presidents for supporting and being leaders in the world. It's been hugely bipartisan, including on some of these tough issues. It gets tougher around some of these issues, but it's really extraordinary to see the leadership that's been now for, how many years are we at? 15, something like that? And one thing is all three of us were global AIDS coordinators. Eric and I finally gave it to someone who knew what they were doing. But, so I think you ask a really important question. You know, having been here in San Francisco in the early 90s when basically a community, which I was a part of, being a young gay man then, I mean, basically we were always at risk, everything we did, no matter where we were. And the stigma and discrimination that was occurring, not just because people were gay, but because they were carrying a virus that everyone was afraid of and didn't really understand. But what was extraordinary is the community came together, not just the HIV positive community, not just the gay community, but actually the entire San Francisco community. It was a beautiful thing to see in the midst of a horror, an absolute horror. And that is replicated all over the world. But HIV, it's like tuberculosis. Eric's working a lot on tuberculosis right now. I mean, most infectious diseases, if there were a Zika carrying mosquito flying around, everyone would be equally likely to get, bit. And unless you're a pregnant woman, well, fortunately, most people wouldn't get sick. But most infectious diseases are great equalizers. They are indiscriminate. Doesn't matter who you are if you come in contact with them. HIV and tuberculosis are very unique diseases in that they prey on the most vulnerable and marginalized. And we think of the LGBTI community here a lot, but it actually is sex workers, people who inject drugs, prisoners, migrants, migratory workers, not refugees, but regular migrants who move for jobs and move from time to time in various places. And there's actually a lot of overlap between those groups, which is pretty extraordinary for an infectious disease to be that discriminatory in a sense. Now, the virus itself is not discriminatory. And what that means, and this is an extraordinary thing to me, and it still takes my breath away every time I think about it, but to end HIV and TB, we actually have to become better human beings. We actually have to create an inclusive human society, or we can't end the epidemics. And really where you've gotten to the point where these are societal diseases. They're infectious diseases, but the persistence of them is because of a societal disease. And the last group I'll mention, then turn it over, is adolescent girls and young women. And this is something we don't think or talk enough about, although we've all been saying it. We will win or lose the battle against HIV based on whether or not we overcome gender inequality. And the reason for that is in sub-Saharan Africa, HIV is now driven predominantly by inequality between men and women, by rape, by abuse, by violence. Most girls, this is extraordinary, most girls aren't even registered at birth because not only are they discriminated against, they're non-existent. They don't exist in society. They're not important enough to even be registered. Their families ask them to leave school, literally, to go sell themselves so that they can bring money into their home. And the gender inequality is fueling this epidemic. And so I'll just end again where I started, what I mentioned. It is such an extraordinary thing that to end an infectious disease, we have to become better human beings. And that's really an opportunity, and we're so thankful to Dreamforce for highlighting that while we're here.
Thank you. Ambassador Birx, I'm sure you have some wonderful thoughts to share. Based on your experience, talk to us about why the non-medical is often the hardest work that you do out there in the field.
I think Mark started out by really framing it well, that it's these cultural community intersections that relate to not only the fiscal status, the economic status of the community and the individuals within the community, it's also the words that are used to describe the communities that create the barriers between us and our public health response. I was really excited about Leader Pelosi talking about the importance of all of us coming together and bringing words together that bring us together in the public health response and that no one can be excluded. And I think what we've really realized in working around the globe is that words at the community level either bring us together or further divide us. And oftentimes when people are talking about marginalized persons, they use very derogatory and separating words to separate individuals further from the community rather than bringing them into the community in order for them to have services. Or frankly, when they go to access services, they're dramatically stigmatized. So we're very careful about the words that we use because I think that's very critical. Words can be uplifting and embracing, or they can be divisive and pull us further apart. The other piece that's really critical in all of this is it can't just be words. A lot of people talk about the issues, but then don't do anything about the issues. And I think partly because it is embraced and enrobed in what people call the culture of that community, but I think our job is to shed a light into those dark areas. And our job is to make sure that in that light comes the brilliance of people coming together to address an issue. And that's what makes me get up every morning. I'm so excited about what we get to do, how we can translate US government taxpayer dollars into not only words that shine light onto the areas of the most vulnerable among us, but the actual to be able to bring those actions, that translation of compassion and concern into true actionable events that change the lives of individuals. And I think Mark is totally correct. We watched how San Francisco is getting to zero. and you look across the bridge and you want Oakland to get to 0, and you want Durban, South Africa to get to 0, and you want Cameroon and Douala in Cameroon to get to 0, and you realize the only way we get there is if we understand precisely what the virus is doing, and we understand precisely what's putting people at risk, and we're ensuring that our actions are abating that every single day.
It's fantastic. Thank you. Dr. Gooseby, enlighten us.
Well, thanks, James. Thank you so much for having me here today. I, too, like my two colleagues have already done, want to acknowledge the role that Speaker Leader Pelosi has played since the very early days in the response to this epidemic. San Francisco, one of the epicenters of the U.S. outbreak, percolated up people who were impacted, affected, infected by HIV in 1981. And there were really very few who positioned themselves in the leadership to embrace and move a process into play that enabled multiple resources coming from state, federal, local, in various aspects of the response to convene around how we should coordinate, work together, share resources, but to engage the community in a substantive dialogue around need, met and unmet. The fear that was present in San Francisco in those early years was appeased by this most senior leadership in the city at national levels, working together with city leadership to put a process in place that brought clarity to what was occurring when there was none, being honest about what was known and what wasn't known, and having the courage, and organizations like the San Francisco AIDS Foundation, like Project Inform, the open hand aspects, Shanti Project, all came in very early to put an enabling component to the community as it worked through a process that identified met and unmet need that ultimately began to define the San Francisco response. That medical core matched with community surround services that enabled people to identify themselves, create safe spaces for the identification to result in a mobilization to create a response, and that response, once better defined and understood, was shared with other aspects of that same community. San Francisco then took it further, again, through Congresswoman Pelosi's leadership, to address the needs in other epicenter cities in the United States through the Ryan White Care Act. That act, again, brought resources from the federal government to state and local service sites for the first time after a decade of just local mobilization resources. The complexity of the individuals impacted by HIV made the response to the epidemic difficult. People were not comfortable in revealing their seropositivity after 1984, once there was an antibody test, to their friends and family. Indeed, the entire evolution of the human rights issues, the civil rights issues that ran concurrent with this, often added fuel and encouragement, but also made it much more complicated for people to stay focused on the medical needs, which were expanding, which were largely unknown and partially understood at the time. No real effective treatments. Early and effective aggressive diagnosis of opportunistic infections became the focus until the late 80s, when the first antiretrovirals began to show themselves, and it wasn't for another 6 years before the early antiretrovirals really became effective, highly active antiretrovirals. That was in the mid-90s. The complexity of getting the community to understand the evolution of the understanding and match that with a meaningful, effective response was the orchestration that required everybody to put in and create those safe spaces so individuals could be identified, entered, and retained. The populations that have already been talked about need to be explicitly identified and reacted to, each population one at a time in the domestic epidemic, and thought about how that individual is retained over time in care really for the duration of their life. The complexity of bringing that to settings that were less developed in sub-Saharan Africa, Eastern Asia, Southeast Asia, Eastern Europe, brought another challenge that I think San Francisco should take ownership around the degree to which lessons learned here, responses developed here, were concretized, evaluated, and shown to be effective, and then transported globally. So really quite a story.
Thank you. Ernest, I know from our work together, so much of your leadership and effort is designed to get progress in some of the non-medical barriers. Talk to us about how you see leadership and boldness in your work.
Well, you know, thank you, Dreamforce. Thank you very much, Leader Pelosi, for everything. I mean, over the years, you have been our most important champion in the Congress. You've been our strategic ally, helping us work with the rest of the members who didn't have your personal loss, your personal passion, and your compassion for people living with HIV. So thank you very much for everything that you have done for us. We really do appreciate it. And I'm sitting here with my heroes and the brain trust of the entire AIDS community. I mean, so if you want to know what leadership looks like, look at these three individuals to my left. They truly have saved millions of lives. Who can say that? The global epidemic is a devastating, terrible story. And the epidemic in the United States is a devastating, terrible story. It is an epidemic that devastated populations across the nation in differential ways. As a black gay man, in the early days of the epidemic when I was in New York, we really didn't know what was going on, and we certainly didn't think it would go on for the amount of time that it has gone on. And we made assumptions about the epidemic that have driven policy and decisions over time. This is an epidemic, a medical epidemic, a disease that has been politicized from its very initiation. Just the notion of calling it GRID was a devastating, debilitating, discriminatory process in the gay community. And so, you know, if I look back on the beginning of the epidemic in the United States, past is prologue. When you start a process by discriminatory actions, marginalization, criminalization, it's no wonder that certain populations in this country still don't have the things that they need. And so in the black community, it's ironic that at the beginning of the epidemic, it was frequently characterized in the media as a white gay man's disease. But people in the black community always knew that it was disproportionately impacting people in black America. And so now, when we look at the data and we see that black Americans are disproportionately impacted by HIV, it's no wonder that it's been more difficult for them to address these issues in their community because they were told by the media that it wasn't a problem. And quite frankly, in an environment where there are significant other challenges, why would you take on something that you've been told is not your own? And so I think when we look at trying to get people into care, and when we look at how we need to integrate both care and prevention, now that we have prevention as care, we really do need to look at very targeted ways to address the issues in communities that have been marginalized over time. The black community, the transgender community, injection drug users, immigrants. I was so glad to hear that issue, because what we know is the laws that we have on the books around HIV criminalization are disproportionately impacting our immigrants. And so if we don't begin to take targeted attention and focus on looking at the ways in which the very systems of care that we have created sometimes act as marginalizing forces in their lives, we'll never get them into care. We'll never get them virally suppressed. We'll never turn the tide against HIV in these populations, and we have to. There's no possible way for us to get to zero if we leave significant swaths of the community unaddressed. And so that's the work. That's the work that we have to continue to do, is to look at new creative ways to take the systems of care that we have today and retool them to address the needs of populations that have not been addressed appropriately to date.
Thank you. We're going to come back this way, especially because I love this question. So, Ambassador Birx, you have an impressively diverse background when it comes to leadership in health and HIV, from research on an HIV vaccine and achieving rank as a colonel in the Department of Defense while conducting HIV research, to your work today on global health diplomacy. Can you talk to us about these various moments from your viewpoint and any particular instances, especially that stand out in your mind, that marked real turning points in the epidemic, both here in the United States and abroad?
Great. I was just thinking, sitting here next to Eric, we still, I think every day, think about those early days and think about what it meant to each of us having. When we trained in medicine in the late 70s, early 80s, we believed we could do anything. We had conquered cancer, we had treatments for childhood leukemia, we had treatments for non-Hodgkin's and Hodgkin's lymphoma. We thought we were really smart. And then patients started coming in, 29-year-olds, 30-year-olds. In the military, we had 10,000 patients coming to Walter Reed, all with HIV/AIDS, all dying, and nothing that we could do to change their individual outcome, which was our sole reason we went into medicine, was to heal. And the inspiration, and I just want to highlight from the very beginning, what drove me, and I think what drove many people forward, were the people themselves who had HIV, who stood up while they were dying, and with compassion and concern for those behind them, stood up and demanded something different for everybody else, even though they were so sick. They would go to NIH and tell Dr. Fauci that they needed a test for AIDS, that they needed treatment for AIDS. We weren't moving fast enough. The pharmaceutical companies weren't moving fast enough. The research was not moving at a pace to prevent them from dying. And they used their last energy to appeal to others. That activism changed the patient-client relationship forever. It changed how we do research. It changed the pace of our research. It changed our level of dedication. And I think it forever is that beacon for other diseases of how to really work on something collectively, bringing the medical community, the research community, the care community, and the advocates together. And the advocates, and the way I got to know many, was because I was teaching immunology 101, because they wanted to understand how every single cell in their body worked and why it wasn't working because of the virus. And because of that, they spoke very clearly to their doctor, very clearly to the researchers, and said, this is what I need. Find me a drug that does that. And ask for that day after day. I see the pictures from those original March on Washington, and the AIDS quilt that was laid out and covered the entire mall. And I see how sick they are. You can see it in every bit of their face, their bodies, how sick they were and how much they were willing to give so that others could survive. So I feel like that is such an inspiration, and following that came the leadership at the political level and the scientific level that brought us today to a place where we could say we have the medical tools to end this epidemic, yet we don't have the ability to implement them in a way that we know is going to create the response that we have. We do in pockets like San Francisco, but then you look to Durban, and then you look to Oakland, and then you look to South Central LA. And many of the factors that put young women at risk in sub-Saharan Africa are putting young men at risk here. And it's not just a medical solution. And that's why the political leadership, the leadership that we have in Congress, and I just want to say very quickly, extraordinary bipartisan leadership. that come together every day over this issue. We have President Clinton, who started with Ryan White and understood how important this was and start putting money globally, to President Bush, who created PEPFAR and expanded both our investment in HIV/AIDS globally and also the Global Fund, to President Obama, who took a $15 billion program and made it a $70 billion program, showing that when we work together as Americans, we not only now have the way forward to end the epidemic, we have work on the cure, we have work on vaccines. I agree with Leader Pelosi, we should have had that a decade ago, but we're making progress. So when I tell a 20-year-old today in sub-Saharan Africa that they have a deadly virus and we're putting them on treatment and they need to be on for life, I can also say, but we're working on a cure. And in your lifetime, we will have that cure. So you need to take these drugs now, but there's a different future for you. And that is all possible because in 1983, gay men stood up while they were dying and said, we need a different future for our community. And the great thing is the political leadership, the scientific leadership, and those that understood that intersection of health and wealth and ability to thrive came together and remain together today. And that's what is exciting for us to be working in this field.
Thank you. Dr. Gooseby, so here we are at Dreamforce. And much of the focus is about what is next for tech and development of Salesforce. So let's apply that same lens to our discussion here and look to the future. What are the next big developments we're going to see or need to see, both here in San Francisco and around the world, if we're going to keep pace with achievement in the response to HIV?
Well, I think the tragedy out there is when we have science that we know, but it is not applied or available to those who need it. That mismatch is present in San Francisco. Different neighborhoods in this city have remarkably different access and retention issues. The ability to get a person identified, entered, and in front of a knowledgeable individual who can initiate treatment that individual person needs to take for really the rest of their life requires a delivery system that remains responsive, relevant, is sensitive and appropriate, is accommodating to the changing needs of that individual as they move through their life and their disease. San Francisco has consciously tried to think and reflect on how that delivery system does or does not interface. The need to maintain a political will for that is evident, and I think that all of us up here have grown in our appreciation of the importance of that, not just domestically, but in every country we work in. Having that political agenda, the political buy-in is critical. And without it, we have more demonstration projects than actual changes in capacity and availability. The science needs to apply to those who need it, but we also need to understand that the needs are about to change dramatically in the global burden of disease. The infectious diseases are going to remain. We need to get better at identification, entry, and retention. We need to get better, as Ernest says, to move toward that cure. It is on the agenda. Debbie's right. This is just on the horizon. A different future is being defined, and we need to aggressively sustain that. But the multiple unmet needs that are presented to funders can get confusing. A priority one year becomes a non-priority the next year. The infectious disease that you were responding to will take advantage of the lull in attention and will rekindle and come back and bite hard. We need to sustain what we know and do. We need to keep kind of the foot on the back of the neck, increase it if we can, while we see non-communicable diseases, NCDs, coming right in behind, and actually are the diseases that are now beginning to predominate in our HIV-positive populations. Hypertension, diabetes, coronary artery disease, pulmonary respiratory problems, cancers, malignancies. Those in 2020, 2025 are going to push into the 60, 70% cause of death rate globally, in many countries higher, and are going to impact the patients that the people that we have been with in just the HIV context are now going to start needing a broader array of services. That pivot will require political will, resources, continuation of what's already happened as we expand the services to cover what is now going to start killing these same populations. The complexity of the individual's self-perception, their willingness to reveal themselves to family, friends, and medical delivery systems are going to play into that. But the tender tension between unraveling or dismantling the system that is already in place for that infectious disease is and needs to be consciously protected. So it's getting more complicated.
Thank you. Mark, as Executive Director of the Global Fund, you oversee financing to programs in over 100 countries and a partnership that has put over 9 million people on treatment for HIV. You have a very unique vantage point in the global response to HIV, so let's keep with that forward-looking theme. What do you think are the next big hurdles we need to get over to continue making gains in HIV around the world?
So, this question comes up a lot, and we all give and should give a litany of reaching the people, procurement systems, supply systems, human resource systems, the same things we actually talked about 15 years ago. The big thing to me is actually change the way we think. So we actually can end this epidemic. We can't make it go away completely until we have a vaccine and cure, which I think we'll get. But we can get to such low levels that it is not a public health risk, that really it is a controlled disease. And if you think about it, most young people today have never heard of HIV, don't know a world without HIV. We can actually get to that, but it requires changing the way we think. If you're just trying to expand services, if you're just trying to do more of the same, we're going to do what we did for the last 15 years, which was unbelievable. I mean, it's unbelievable. But 15 years ago, it was really a massive response to end disease, to end the dying, to intervene. We could spend money almost any way you wanted to, and you were going to have a big impact. But when you're trying to end an epidemic, you actually have to think in a very different way. And Bill Fay wrote this great book, House on Fire, about the end of smallpox and how we ended smallpox. It's the same with Ebola, for that matter. You actually have to think differently, which means going where the new infections are, understanding that there is no such thing as an HIV epidemic globally. There isn't actually a national HIV epidemic. There are microepidemics in each country, and each one of those microepidemics is driven by a different cause, has a different set of responses. So how you respond to an epidemic that's driven by adolescent girls and young women is very different than how you respond to an epidemic that's driven by people who inject drugs. But if you don't know that and understand, if you don't put the right pieces together, and if you don't go where the new infections are, you're never going to end the epidemic. So what we need to fundamentally do, given the topic here, is be bold and actually say, we will end this epidemic, which we're all saying, but then change the way we think and act to respond to that. And that means not doing things the way we've done them for the last 15 years, which was great, and it's gotten us to this point, but now we need to change. And that's the opportunity of today. And if we do that, we will absolutely end this epidemic as an epidemic. And the really cool thing is that if you reduce transmission rates to that low a level, a partially effective vaccine is enough. You don't need a 90–95% effective vaccine. You probably need a 50–60% effective vaccine, because your transmission rates are so low that if you then focus your vaccine into the areas where the epidemic is left, you can actually eliminate it without a 90% effective vaccine. This is all doable in our lifetime. But to do that means changing the way we think. And that also means changing the way we behave towards each other as human beings, because the people who are left there, the people who are left with the high transmission rates, are those people left behind by society. It's the marginalized populations that we talk about. And so we have to change the way we think about the virus, but then we also have to change the way we think about human beings. And not just tolerate and accept, but embrace, love, and welcome. And if we do those two things, this epidemic will go away. To do all that takes money, it takes political leadership, and I really want to thank again Leader Pelosi. I mean, no one has done more for this epidemic than Leader Pelosi. Actually, you asked Deb a story about something I will never forget. When she was speaker and the reauthorization of PEPFAR was happening, which also funds the Global Fund, as speaker, she went to the well and pushed that the bill be passed. It's very rare for a speaker to go to the well to push for a bill. And she went and did it. And I won't even tell you all the things that she did before that with the Rules Committee and a few other things to make sure we got to that point. But there are very few people. But that political leadership is going to be necessary. And it's going to be the political leaders in Congress, which has been there in bipartisan ways. It's going to be heads of state. But it's going to be the people in the countries, because they're the ones who have the responsibility. They have to change the way they think. They have to change the way they treat other human beings. And we all have to do that together. But it's so exciting to be in the position. I mean, who would have thought 15 years ago in this city we would be in a position where we're going to be sitting here today to say, if we just do a few things, we will end this epidemic. It's extraordinary. It's extraordinary. We just need to do it. We just need to do it.
Let's do it.
Yeah.
Ernest, I'm going to ask you to bring us home. So, since the New York Times first published its reports in 1981, when you were a junior at Columbia, you witnessed and lived from the perspective of a young, black, HIV-negative, gay man, devastation in your peer groups in New York and in DC, both politically and socially. And then you flash forward today, where science, funding, and political will at multiple levels is enabling things like the Getting to Zero initiative here in San Francisco. So from your perspective as an advocate who has facilitated much of this tremendous progress, and as the founder of the Black LGBT Pride Movement and the National Black Gay Men's Advocacy Coalition, what's our unfinished business? Who's still out of care? And what do we need to do right now to address their needs? And you've got 2 minutes.
Well, I'm going to go back to Mark's comment, which is now going to be my new mantra: welcome, love, and embrace. If we could create those kinds of systems of care for the underserved and the unserved, if we could take away the stigma and shame that we have dumped on this disease over time, we'd be where we need to be. And so it takes money, it takes political will, it takes creative thinking. I think that it's already been said what we need to do. How will we get there with populations and communities who society has essentially marginalized and decided that they actually don't matter? That's the question. That's the work that we're doing at the National Black Gay Men's Advocacy Coalition, mentoring young black gay men who understand and care deeply about their lives, want to be healthy, want to be protected from HIV, or want to remain healthy if they're living with HIV. Those young black men are our future, are the people who are going to be demanding the cure, who are going to be demanding the vaccine, who are going to be caring about the women and girls in sub-Saharan Africa. Those are our next set of leaders. And dramatically, for me, what I know to be true is I didn't have that group of older black gay men because they died. This is the first generation of guys who actually have men who've lived and who have wisdom and who have the ability to impart information to them and share and support them as they move forward in their lives. And so I'm really hopeful, super hopeful, that with the scientific advances that we continue to make and with the political will that we continue to have in Congress, the bipartisan political will, that we will get where we need to be, and we will end this epidemic. And San Francisco will continue to be the beacon, the model to be replicated around the world.
And I think I'll just close on that. I think everyone in the room is acutely aware that San Francisco was ground zero for the HIV epidemic. And then just recently, our San Francisco Department of Public Health released a report that demonstrated in 2015, there were 255 new infections. Now, let's be clear, that's 255 too many. And some of our hardest work is ahead of us. as we work to eliminate disparities in health and bring more people in from the margins. And that means developing innovative solutions to better meeting the needs of our trans brothers and sisters, of communities of color, of our aging HIV-positive population, and of people who struggle to keep a roof over their head, just to name a few. But momentum is on our side. And because of the extraordinary leadership of people sitting up here on the stage and speaker leader Nancy Pelosi, who has been our champion since the very beginning and shows no signs of letting up the fight, we are hopeful that soon, one day in the not too distant future, we will see a day where San Francisco becomes the first city to end HIV transmission. I want to thank you all for coming. I want to thank our wonderful panelists here.
Yeah.
And I want to remind you, we're trying to raise $1 million for RED. And there's a matching gift on the table from Mark and Lynn. So if you do one thing to join this effort, go by the RED store, find something for yourself, for a family member, for a loved one, because just in making a contribution there, if we harness the entire collective energy of the Dreamforce community, we will get there and so much farther. Thank you and have a wonderful day.